Mary Cuny, Spokane County Commissioner.
Chuck Hafner, appointed citizen.
Linda Thompson, City of Spokane Valley.
Kate Burke, City of Spokane.
Andrea Frostad, appointed.
Kevin Freeman, City of Millwood.
Josh Kearns, Spokane County.
Don Condon, appointed citizen.
Brian Beggs, City of Spokane Council Member and Chair for today. And we'll start out with some citizen input. The first speaker I have is Jacqueline Gallion.
Hello, Jacqueline Gallion, City of Spokane Valley. It was Robert Kennedy Jr. who said the checks and balances in our democratic system that are supposed to stand between corporate power and our little children have been removed. And there's only one barrier left, and that's the parents. Lies are being told about us, about vaccines, about vaccine programs, about infections, and about our children. The facts and lies are tangled together in one clustered up mess, making it almost impossible to tell fiction from fantasy. And I've untangled some facts. Merck being on trial for fraud regarding the MMR and Gardasil vaccines is fact, not fantasy. Vaccine failure, outbreaks of whooping cough, chickenpox, mumps, and measles in fully vaccinated people is fact, not fantasy. Roughly 1% of vaccine injuries and deaths are being reported is fact, not fantasy. Vaccine injury that leaves a child chronically ill that is reported by millions of parents worldwide, with injuries recorded in published case studies with symptoms actually listed on the federal vaccine injury table are fact, not fantasy. Believing that being injected with a vaccine cocktail makes a child healthy is not fact. That is pure fantasy. When parents are coerced, bullied, feared, and made to feel guilty for exercising their freedom, it is not covered by the news. It is a single event hidden from view. And when a child is injured by a vaccine, hit by a seizure, a loss of language, or a loss of life, it is a single event hidden from view. When they come to public health for help, they're mocked, shunned, ignored, gaslighted, and sent home. We're told to vaccinate for the greater good, but where's the greater good when those vaccines cause harm? Can the products that are being peddled even do what they are claimed to do? No. Can any vaccine create herd immunity? To create herd immunity, a vaccine has to be able to prevent transmission and not wane. Is there a vaccine on the current schedule that can prevent transmission and not wane? Whooping cough, mumps, measles, chickenpox are all breaking out in fully vaccinated groups, and their makers are in court across the globe on trial for fraud, for malfeasance, for lying about what their products can do and lying about the harm they cause. The ends don't justify the means. The top-down, corporate-captured, population-level public health on a one-size-fits-all vaccine medical procedures policy must be mitigated by the parents' absolute right and to accept or refuse. I also want to point out that for 2.5 years, many of us have been asking for a roundtable discussion regarding vaccine science, safety, and school exclusions and more. And our requests have been ignored. And not once have we been made an agenda item here in these meetings. And that is one of our requests still. So thank you very much.
Thank you, Ms. Gallion. Next I have Raylani Bonner.
Kaylani Bonner, Spokane County. I would like to speak about my concerns about House Bill 1638 that was passed. I'm deeply grieved and troubled that lawmakers passed a bill that deepens the reach and scope of mandates for a liability-free pharmaceutical product, MMR, liability-free due to the 1986 National Childhood Vaccine Injury Act, an act which has well-documented failures and shortcomings, and furthermore is classified as unavoidably unsafe by the Supreme Court. This product has known and unknown side effects, and the unknown side effects chronically persist due to many unsettling factors, some of which are the financial conflicts of interest that go unchecked among policymakers. Everything I'm saying is well referenced. I'll email it to everyone here with the links. That was from a Vaccine Safety Commission report looking at conflicts of interest. The capture of less than 1% of adverse effects associated with an aftermarket vaccine, and the fact that vaccine safety, and that's in quotes, Studies lack true placebos, with only 1 out of 30 vaccines routinely injected into babies and children using a true placebo. Lastly, and potentially the most damning, is the fact that vaccines are assessed for risk individually, though they are administered in multiples. The removal of the personal belief philosophical exemption for the MMR vaccine attempts to bully and coerce a minority of Washington state parents and or the adult daycare staff or volunteers to receive an injection for their children or selves that they are opposed to. Because of the wording of the religious exemption, many citizens relied upon this exemption in order to exercise their religious exemption or objection. Others used this because they had a child injured by a vaccine, but could not obtain a medical exemption for siblings, an egregious reality for many parents, and one whose amendment was wiped out at the last stages of this bill. Some citizens affected now face losing their jobs, and that's in the new Section 3 of the RCW, or their children's access to daycare, running start, public or private school. This discriminatory segregation against a small minority impacts the poor and middle class with the most cruelty and disregard. The wealthy can quit their jobs to homeschool or pay for private tutors. To add injury to insult, this unfair targeting completely ignores a primary contributor to outbreaks, vaccine failure, and the spread of measles in fully vaccinated individuals and populations. As an activist for medical freedoms and personalized medicine, I can assure you that those who oppose this vaccine will not comply. They will face financial loss and hardship if that's what it takes. To think in America, of all places, to the shame of lawmakers who supported this and the lobbyists and campaign donors they are beholden to. Restricting educational opportunities, segregation, and unfair discrimination, that is a legacy of vaccine mandates and the erosion of exemptions. If you really hope to address vaccine hesitancy, you must lobby the State Department of Health and our lawmakers to address the serious flaws with the childhood vaccine program, and I second Jacqueline's comment, as well as the things that we've requested here to be done.
Thank you, Ms. Bonner, and my apologies for misreading your first name the first time. Good to meet you. Next, I just really have the first name, but Ina?
My name is Ina Mayurov, and I live in Spokane County. I would like to speak. I was asked to be here by the Russian or Slavic community, which consists of over 40,000 people here. We are very concerned on the recent law changes in regards to HB 1638. We had several meetings in the church within the District 81 to raise our concerns, because a lot of parents are facing the issue where they have to pull their kids off the school and provide homeschooling, which will limit their income because they would have to quit their jobs. And again, we would like to bring that to your attention and ask you to please reconsider and help us to navigate this issue for our families, for our communities, because it is huge. And we believe it's going to impact negatively on the state, because a lot of people will be applying for the public health, not health, but for public assistance, which includes cash and food stamps. And again, we just want you to know this problem is very big and serious, and we would like you to take it into consideration. Thank you so much.
Thank you so much for your comments. That brings us to the ends of the public comment period. We have two matters under our consent agenda, the meeting minutes. They're in your packet. Does anyone have any corrections or additions to that?
No, I'll move to approve.
Second.
It's been moved and approved to adopt the April 25th, 2019 meeting minutes. Is there any discussion about that? Seeing none, all those in favor, please indicate by saying aye.
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 Opposed? Any abstentions? That's unanimously approved. Next item, vouchers for April 1st through the 30th of 2019. And there were a few questions that Mike Riley will be answering. And again, just a reminder to the greater audience, we're circulating these early and then finding out what the concerns are from board members and then addressing them in that interim time. So take it away, Mike.
All right, thank you very much. Yes, there was 3 questions that came out, and in your packet, you would have received the description of what voucher it was, what number it was, what the dollar amount, and the description of the item. But I wanted to take it one step further and actually answer the board members' questions. So there's some questions on here, and the example is, the very first one was a company called Maintenance Solutions, and the question is this a contracted maintenance company that we use? And it is not. We have in-house maintenance crews. So our in-house hired staff does all the maintenance in the main part of the building. This was actually a vendor that we buy. This was 24 cases of industrial used glass cleaner that we purchased. So this was just a purchase for the maintenance department to do the work that we do in-house currently. The next one down was the FedEx. Everybody's familiar with FedEx shipping, and the question was $1,200 seems like a lot of shipping for the size of our company. And the answer to that is it's about average. There has been months as low as 800, and one as low as 600, some in the 800s. Oftentimes it's at 11 to 1,300. And there's 4 programs in the agency that uses the FedEx for shipping. That is the tuberculosis program, Spokane AIDS, the Medicaid-assisted therapy, and the living environment programs all use it. And these are all shipments that go to the state DO lab. We no longer have our own lab here in-house, and so we use the state Department of Health lab for those, and these are all things that we have to ship out to get those tested for various items. The last question that was asked was a company called NDM Technologies. And the question was actually, what's our threshold for capital and what's our renewal plan for the equipment? And the price was $26,000. This is to replace our old core switch system on all the floors to make our computers run faster and work more efficiently. To answer the question is, we went to our capital is over $50,000 now. We sort of followed the county's lead about 2 years ago. I worked with the Budget and Finance Committee and this board to follow all our thresholds for purchasing, following the county's one as well. So we sort of tagged along with the way they purchased at their levels for the various bids and quotes and when we have to do those. And as far as the replacement plan for our equipment, PCs on people's desks, there's a 5-year plan to do them. I know it's not always 5 years because I've had mine for 6 years right now. So I know that mine didn't get replaced in this last little bit, but I think I'm on the next list to possibly get one. And then the big equipment in the IS department is on between a 5 and a 12-year plan on major servers and other grades like that. So that answers the questions that was asked.
Any other questions about the vouchers? Is there a motion to?
Move approval of vouchers presented.
Second.
Any discussion?
I'd like to
Councilmember
recuse
Thompson?
myself, please.
Okay. Councilmember Thompson is recused.
And I should explain, Greater Spokane Substance Abuse Council is paid, which is my employer.
Okay. Thank you. Any other discussion or matters related to this? Hearing none, all those in favor, other than Ms. Thompson, please indicate by saying aye.
Aye.
Any opposed? Any abstentions? The vouchers are approved. Where our next item is to go into executive session for review of personnel duties pursuant to RCW 110 1G. And how much time? Okay, so she gave me a different number. So we'll be in executive session until 12:55 unless we extend it. So we'll have to clear the room for that. Looks like 12:55 to me, so we're back in regular session. And we have 2 resolutions to consider. The first one is resolution number 19-03, and it essentially is going to conclude Mike Riley's temporary position as co-interim administrator, and including the temporary pay increase that went with that. And it's going to confirm that Ray Byrne is going to be the sole temporary interim administrator with a supplemental pay increase of 5% to his already increase of 10% as the co-administrator. And we've had a report from staff that Mike is much needed in the finance department to deal with the result of somebody leaving and some matters to be cleaned up in the past, that everything's going well going forward, but they're going to need his attention to that. And Ray has graciously agreed to shoulder more of the duties. His staff is not as excited about that, but they are well positioned to keep things going while we look for our new administrator. But any questions or comments about well, I guess I need a motion to adopt it from somebody.
Let's see, okay. I move that we approve Resolution 19-03, approving the conclusion of a temporary assignment to co-interim administrator and corresponding temporary pay increase, and to the appointment of a sole interim administrator with a supplemental pay increase.
Second.
It's been moved and seconded. Any further discussion on this resolution? Hearing none, all those in favor, please indicate by saying aye.
Aye.
All those opposed, nay. Any abstentions? Hearing none, the resolution 19-03 is adopted unanimously. That next brings us to resolution 1904. Do I hear a motion to approve that?
Yes, I'll make a motion to approve that.
I'll second.
The labor contract for employees, Spokane Regional Health District, who are members of the Washington State Nurses Association for the period of October 1st, 2018 through September 30th, 2020.
Second.
That motion's been moved and seconded. And Sue, you wanted to tell us a little bit about this?
Yeah, I can. Hopefully you have this in your packet, but we've been bargaining with the WSNA union since last fall. Their contract expired last September. We moved forward with the agency with the 2.9 COLA for non-repped and PTE represented employees. We finally came to an agreement with WSNA and they took it out to vote and ratified their contract. So basically it would be giving them the 2.9% COLA that would go back to January 1, which is what non-repped and PTE members received. And that the medical costs would be the same as the non-repped and PTE members. That would be back to January 1. And then going forward, there'd be a weekend premium pay of $4 an hour. And that's pretty standard in the nursing practice in the industry. Here we only have maybe about 20 nurses at our agency, part of the union. And on a given weekend, we might have 1 or 2 nurses that work a Saturday or Sunday, and those are typically for a half day. So the financial impact is minimal. And we also looked at increasing the preceptor pay from $1 to $1.75 per hour with management pre-approval, and bilingual pay from $1 to $10 per hour. And there again, it's typically not something we use very often, but if we hired an interpretive service outside, it's a lot more expensive than that. So I think both sides finally felt that we came to an agreement that we thought was beneficial to the nurses as well as the agency. And we also gave a market adjustment of 1.1% for the public health nurse 1, 2s, and 3s. And then a 7.7% adjustment for the nurse practitioners. The district, our side feels that is needed for recruitment and retention issues. We've had a couple nurse practitioners leave. It's been hard to recruit, and our treatment services program continues to grow. So, any questions?
Yep, any questions for Sue?
I just want to clarify, so the contract timing was October 1, 2018, but we're only going retro back to January 1 of
Yeah,
19.
because when we do the contract, traditionally WSNA's contract run off the calendar time.
Okay.
And so even if we were to ratify their contract, any wage adjustments traditionally, and for our past history since I've been here, has always been made January 1, even though the contract is earlier.
Perfect. Thank you for the clarification.
Any other questions?
Just to clarify something too, I think Sue mentioned the market adjustment for the ARNPs was 7.7. It's 7.1.
1.
Thank you. Any other questions or comments? All right, it's been moved and seconded to adopt resolution number 1904. All those in favor, please indicate by saying aye.
Aye.
Any opposed? Any abstentions? All right, with that, it's approved unanimously. It'll be circulated around for signature shortly. Next item are reports. The chair report, there's nothing specific from the chair. And let me go around. I don't know that really many of the committees were meeting, but I'll find out. Anything from, except one that I know of, the special committee. But anything from budget and finance?
We had a meeting, I think, was it May 2nd, when I think early in the month that we had a meeting, and we just talked about kind of where we need to go for laying out the schedule for the budget. And so we've looked at adjusting some of those times. And so I'm not sure when our next
It's on the agenda, on July 11th.
July 11th. Because this one says May 2nd on the one I have in front of me. So July 11th will be our next meeting, and we'll be talking about the budget at that point.
Anything from education and finance? Anything from policy?
Thank you. Yeah, we did meet, and what Dr. Lutz and I came up with was kind of a series of points that we saw that were synergetic to our strategic plan, and we brought them forward to the committee. There wasn't enough of us to really take a vote on it, but one committee member was there and liked them, so we'll revisit them again, pass them as a committee and bring them to the board so that you guys can take a look at what kind of focus areas we want to dive into through policy. And then we had a pretty good discussion on what is our role as the Board of Health in terms of lobbying. And so I think we're going to go over that closer to session, just so all of us board members are up to speed on that as well. And then our next policy meeting will be going over this. And once we vote on the focus areas, we're going to bring that to the education committee and working with them to try to figure out who we want to bring in to do some workshops for our board, where we can learn a little bit more about these topic areas and maybe drum up some ideas of policy or things that we need help with at the state level. So
Thanks for that report. We have not, and I'll let Dr. Lutz talk about that in his report when he gets to that, because I think there might be a plan for it. But good. Councilmember Thompson.
I just have a question about the committees. Is it okay for us to go to other committees? Can anyone go to any committee? My committee hasn't met for probably a year. And I'd like to either take a more active role in that committee, or I'd love to go to policy committee, because I think that there's action happening that I think is important if we're going to talk about workshops. How does that structure work? I guess I'm just asking how that works.
I don't believe there's any limitation on it. The main thing is to make sure you're on the scheduling list so you know when it is. So I will.
We have to avoid a quorum of the overall board, though, too, right?
Right.
So, which is 6, I believe.
Okay.
And the other thing that we discussed at the policy meeting was, do we want to join forces with the education committee? Because there's a lot of synergy between those committees. And we did talk about if we did do it and we were going to exceed a quorum, we would just put out a notice and meet in here. So it could be open to the public, and which none of us had a problem with, but there was only 2 committee members, so we want to bring it, we want to talk more about it at our next policy meeting.
And I've lost track how many members are currently on the policy committee, just 4? So that means if you want to. Oh, and the education committee?
How many members?
I think
3?
there are 2. There are 3?
3. So
who all's on that? Oh, okay.
So it sounds like you can start attending the policy committee meeting without a challenge, as long as you get notice of it.
Okay.
We can add you to our list.
Okay.
Yeah.
Thank you.
Great. Okay, and then who's going to give the special committee report? Is that
It's your turn.
Mary?
She's tried to get out of it, and I won't let her.
I do keep trying. So we met. It's been a little while since we met, because we're waiting for the call for applications has closed. And so the firm that we've hired to help us, they have been culling through those applications. They've identified on a list that they've sent to us people that they've interviewed, people that they, I think at this point, have still want to interview, and then people that didn't meet the qualifications that we're not interviewing. So we've seen that list the committee has as we've gone along. So we meet with them on June 3rd, Monday morning at 7 a.m. is our next meeting, and the firm will be here in person to talk to us and talk through. And so at that point in time, we will be figuring out what the next steps are. We're hoping to have it come down to 3 to 5. Then figuring out who's 7. 7. New information. That then we'll be kind of working through that and then narrowing it down to then further have, identify people that will be coming into the community to interview here. And then that'll, like I said, that's part of what we will be talking about next Monday, as well as to what that true procedure is. And so for the next meeting, we'll have that information for you so we can hopefully let Ray get back to his duties in a timely manner. Anything else?
No, you did it right, because Monday is an important day for us.
Yeah.
We got it down to 7, I think 7 applicants or 6 applicants, and we'll be analyzing and see if they meet our needs. And again, as I think we stated, if they don't, then we'll go back to the drawing board. So hopefully it won't happen that way. Are you exhausted yet, Ray? Or?
I know.
Okay. All right.
So Monday morning at 7 a.m. will be an important time.
Any questions for that committee or any comments? Keep up the good work. You don't have to worry about too many people showing up at the 7 a.m. meetings, I think. That's probably true.
I'll remind Karen that she will be there.
Okay, next administrative officer report.
So don't really have a report, just got 2 quick announcements. One is the health policy position. That is still open. We've been going through the applicants that we have. Hopefully we'll be narrowing that down. So a shout out to you guys too. If you do know anybody that you might send our way, please have them go to the website and apply for that position. We're going to leave it open for a little while longer. So, and then also our public information officer has resigned. Yesterday was her last day. So we're finalizing that PD and we'll be going out with that shortly also. So.
I do have one question.
How long is it going to take, Ray, to get that new person on board?
Which one?
The information officer. Kim's leaving. Any idea?
We don't. We're ELT and the information communication department are doing finalizing that PD right now. So hopefully by the end of next week, we'll be going out. Typically we advertise for a minimum of 2 weeks. So we're probably looking at another month before we narrow it down and start doing interviews. And then by the time you complete that, so we're probably another 2, possibly 3 months out.
Okay, so in the meantime, you do have interim people that will be taking over?
Correct.
Okay.
Any other questions or comments for Ray? Seeing none, I'll turn it over to our health officer, Dr. Lutz.
Oh, good afternoon. Just a couple of comments. With respect to ongoing work around opioids and suicide prevention, we had our community forum at the beginning of the month. It was well attended. We would have always liked to have more people there, but I think it was a very good showing. The feedback that we got was exceptional. It was great to see a number of board members there, so thank you for your attendance. It's a first step, but again, I think that the response of that was very positive, and so next steps are being planned. With respect to suicide prevention, we had our second strategic planning meeting last week. Again, more than 30 people in attendance, and so that's really encouraging to see the continued participation with the plan of having an actual plan that will be finalized by mid to the latter part of summer, and then moving forward. We've been looking at trying to find financial resources, grants or other funds out there to really sort of assist in that work. So stay tuned for that, and I'll keep you abreast of that. Also, with respect to opioids, we were pleased to have Mr. Graham, who is the Region 10 Health and Human Services Regional Director, here in town a couple of weeks ago. A number of us met from the agency. Commissioner Cuny was also in attendance, so thank you. We also had John Colton, who is Senator Murray's assistant, in attendance. And Mr. Graham was very encouraged, was very impressed with the work that we're doing locally. The two take-homes that he commented upon to me by an email was he was really impressed with the data center and the dashboard, which will be discussed today, and also the ongoing work around women and pregnancy and opioid use disorder. So again, really shout out to the work at CFS and then the OTP programs working collaboratively to address that issue. So the only other thing I wanted to mention, two things with respect to communicable diseases. The flu season, quote unquote, is officially over, thankfully. Not as bad as last year, but certainly it was notable. And then with respect to measles hasn't gone away, unfortunately. So there was another cluster that has been identified. West Side, we've had 9 cases as of this time. 6 of those cases in Seattle. 2 of the cases in Tacoma, and 1 in Snohomish County. All adults, with the exception of the 1 in Snohomish County who was an adolescent. There is a common point of contact that occurred in SeaTac, which is interesting. There is 1 out-of-state person who has measles in Oklahoma who also was in SeaTac Airport at that time. And of the 9 cases, only 1 has been fully immunized. So everybody else has either partial immunization or has not been vaccinated. So of note that only 1 was vaccinated. And that's it for me. Questions?
Any questions on the health officer report or comments? All right, you're up on the legislative report now.
Yes.
Microphone back on. In your handout, you will see yet again another color-coded document. And what this represents is a summary of this legislative session with the various priorities that were identified by the board at the beginning. Again, color-coded. Yellow is first tier. Rose-colored, I think, is second tier, and blue is the third tier. So you can see that, again, a number of the priority areas that the board identified were signed into legislation. And then following, you'll see a number of other bills that were either signed or did not pass that were somewhat related and or were identified by either WSALFO or the state board or WASAC as having public health significance. And at the end is a summary of some of the funding that was directed towards public health. I thank Anne for putting this together. She made sense of my somewhat illogical document that I sent her over the weekend. Any questions then?
I have a question. Sorry. That's okay. I always have something to say about legislation. I love this work so much. One of the things I'd like to see us do is have our legislative liaisons or lobbyists with different groups meet together, because with the Washington Association of Substance Abuse and Violence Prevention, that is grassroots with community mobilization of substance abuse and violence prevention, we had a lobbyist working these bills very heavily and met every week about these bills. And it would be really nice if we could come together with other legislative groups or representatives and have even a more united front, because the tobacco vapor tax and of course tobacco 21 were huge partnerships that got those through. So I would just like, I don't know if that ever happens, but I think it'd be, and I don't know how it could happen, but I think even a conference call, or I know they all work together in Olympia and even at the national level, but I think it'd be good to somehow have some even discussion or community gathering of the groups that are advocating.
Yeah, I think that's a fabulous idea. And, we have at Spokane City Council have our own kind of governmental affairs person. I'm sure the county has people. So, and maybe at the beginning, before the session starts, figuring out what do we want to be working on together? What do we need to know about? So,
Just one comment, Linda, in the past, and I don't know if I recall this correctly, but there were those issues that we did get together to find out what each other was doing so we could be in support. Again, that's probably a beginning again to seriously consider that.
Yeah, I think it is excellent that it was happening because there are issues like I had reported on the theaters wanting to have alcohol in all theaters. And that really affects our children and reducing underage drinking and just for those in recovery not having to sit in a movie theater and have beer sitting beside them or whatever it would be. And I just think that's a health issue. It's a community norms issue. And there might be something we haven't thought about that would be a health issue that maybe the food industry or the hospitality industry, is hoping to do that we could at least, work together and see. So I'm not sure who could do that, but I would certainly volunteer to help with that. We're having a WhatsApp meeting next week or the week after in Olympia to talk about our champions. We're going to be championing some legislators, which I think would be great for the champions who help move our legislative agenda forward to send a letter from the chair or the board or someone to say thank you, because often they hear us saying, please don't do this, or here's information, or here, let us educate you about this. But a thank you for good policy is important as well. So.
Well, I would have thought that every municipality has a legislative grouping, and perhaps we can initiate getting together and coordinating for those people that are either the head of that particular agency can sit down and meet together so that we can have that mutual cooperation with each other.
Okay.
Yep, I strongly support that as well. I also wanted to mention, I'm not sure if it's captured here, but at the last minute, we did get several additional spots at the WSU Medical School, which was a huge lift. Particularly, my understanding was the 3rd District legislators really kind of made that happen at the last second, so that will help us. Any financial report, Mike?
Yes, thank you. Thanks to the newfound freedom of the resolution you passed a little bit ago, I will be able to give a financial report every month. That was a request to the Budget and Finance Committee. They want me coming up here, and if I just have a little bit to say or a lot to say, I should be up here monthly and reporting something out. And I apologize I haven't been able to get done at that time. Another apology I owe to you right now is there is a item in your packet that has about a 2-page item front and back there that has some numbers on there. And of course, I normally will always want to get these out to you with the packet that goes out a week ago for Friday last week. And I wasn't able to get that out. The finance staff was still working on finalizing the numbers for the 2018. I want to report today a little bit on the 2018 final numbers and the 2019 year to date of where we are as an agency going on at the moment. And I really appreciated my staff who had to come in 2 of the 3 days over the weekend to work on getting those numbers finalized. The other reason we're under pressure to get those done is our calendar year for fiscal is the calendar year. So it's our fiscal year is the calendar year. So December 31st is our cutoff. We want to make sure we get the right expenses and revenues back into that time frame that belong in that time frame. And so we have a May 31st date of getting our annual report into the auditors. And so that is tomorrow. And we're going to meet it, and it's going to go in. And so I'll be done with these same numbers that are on the sheets before you today. We've also already been approached by the auditors, and they want to come to the agency on July 8th. So July 8th. I'm hoping they're going to come one time this year, not a split time like they did last year. That caused a lot of commotion in finance and the building and programmatic. And so I'm hoping that we can really get them to come here and do the full audit in one swoop. So what I have here for you are I have there, and I will promise to make sure to get those out earlier in the future. So I'm going to be coming every month, giving some type of report. I'm hoping to give a little update, at least on the year to date, every couple months or so. And so the first thing we have is this is the sheet that sort of shows our actuals from 2015 to 2018 on agency expenses, and then our 2019 budget. As you know from the past, pretty much from 2016 all the way back to about 2004, we were about a $20 to $25 million agency all those years. It might have been different expenses, it might have been different funding, but we very much were in that range. As you see, for 2017 actuals and 2018 actuals and the 2019 budget, we're growing. We've grown over the last couple of years, which is another reason why we needed more of the whole building. So we're pretty much occupying the whole building now. And we have the whole building now of place, and have to really consider as we get new grants in where we're going to put those people and how we're going to house those people. So, because as you see, the FTEs are growing as well. Moving down to the revenues. Revenues come in various shapes and forms. Again, this is just a trend line right here. If you look on the back of your first page, I actually have the 2017 and the 2018 comparables by the actual expense by category, and then as you move down, you can see the actual revenue that came in as well. And then the other, and so because one of the requests was sort of look at the categories of where our money comes in and how the money comes in. And so this one right now are on the agency, because I just got those numbers in. One of the requests from the Budget and Finance Committee was seeing more of a breakdown by division. And so as I go to the 2019 year to date, I did build the agency expenses by category, the agency expenses by division, and then the agency revenues by division. And I believe next month when I come to report to you, I'm gonna get a better breakdown of the year to date and the 17-18 actuals by division, because I know that was the request of the Budget and Finance Committee. So I will have those for you at next month's meeting. I know you haven't had a chance to go over all these numbers and see there. But overall, what it tells me, especially on the 2019 year to date, is this is through April, so we're a third of the way through the year. In most categories, we're sticking right at about the 33. The overall expenses and the overall revenues are at 33 or above. Expenses at 33, revenues above. A couple of outliers are like the capital equipment. That just meant we bought a bunch of capital equipment up front at the start of the year. We won't be buying more than that at the end of the year. We won't be going over that 200,000. But we just did some capital improvements earlier in the year as part of some of the remodels that's going on upstairs. So I will be reporting more often and also have maybe some other like Kim Kramars or somebody else from finance come down and give reports as we go along and move through the budget, because I do have the help of Kim Kramars and Paula Maxwell that's helping work the budget part of things with the division directors and the program managers. So it should be a nice, smooth budget process this time, and I'll probably bring one or both of them to the next Budget and Finance Committee also. So I know you just got this, so I'm not looking for major questions. If there are any questions, I can answer them. But I do want you to have a chance to look through that. And if you have any questions as you look through it later on, feel free to email me or call me, and I will respond with the answers. So any other
questions or comments for Mike?
I just wanted to, I think it should be mentioned that there is a reserve.
There is.
And so that shows some responsible financial.
Yeah, and okay, and I was actually going to bring the reserve next month also. So I was going to talk to him and talk to Joel and get those out to the whole board of where the reserve's at. And because right now, as we're finishing the final report for tomorrow, I want to make sure my reserve numbers match up with what she's reporting on the annual report. And so I did hold off on the reserve today, but I will definitely get that out to the board at the next meeting.
All right, thanks so much,
All
Mike.
right, thank you.
And thanks Finance Committee for giving him some direction on that. Appreciate that. Okay, next we're kind of switching gears and going to some information that's going to be presented. Looks like we have Stacy.
Hi. Looks like we're ahead of the agenda, so if you need to cut me off, do so, because once I get going talking about this stuff, I get pretty excited. So I was asked to come and speak to you today about a major product that we've rolled out from the data center in close collaboration, looks like they left, with our communications team. It's called County Health Insights. It's our new data hub platform. Demonstrates how, as public health, we're continuously improving the quality of our services, trying to keep up with the times. I think what I wanted to do, though, is kind of ground you in what is the data center, what do we do, how do we fit into this concept called public health, and then allow some times for you to actually look through this new website that we have, because it is a resource that we're asking you not just to use, but also help promote, because we believe you have a lot of constituents that could benefit from the information. So foundational public health services, you might have talked about that as the board in the past year or so, remains a hot topic in public health across the state. The conversations continue now. This is a model. I'm not even sure if this is the current figure that's being promoted. I've kind of seen the wheel or the circle, but conceptually what this tells you is public health professionals and experts and policymakers have come together and said, what are the critical or foundational public health capabilities and capacities that every community in the state of Washington should have access to promote and protect the public's health? And so you can see what this does not say is that it's all that public health does, but it's the critical, what we need to maintain foundational public health services funding for. So you can see at the bottom here, some of the foundational capabilities would be assessment, all hazard preparedness and response, which I think you're going to hear a little bit from today, policy development and support, communications, community partnership development, and then organizational competencies like quality improvement and financial controls, et cetera. So the data center fits here. We support all the other programs, but the data center is focused on providing non-communicable disease surveillance of population health and well-being issues. So that's a core function that we hold. We're really fortunate in the data center that we have expertise across a number of different data and methodologies, and so we provide a lot of support with community partnership development and the organizational competencies like quality improvement, performance measurement, et cetera. So just kind of grounding you that data is very much public health, but when I talk about the data center or data, I don't just talk about data. It's also about providing the services that people can then use to make decisions from that data. So the methods, tools, technical assistance. So about the data center, we are one of those growth areas of FTE. When I took over the data center in, I don't even remember how long ago it's been, but it was a staff of 4. And we have grown to now we have a staff of 11 with expertise in a lot of different methodologies and data sets. Part of the reasons that we've been able to grow so much is because of this concept that we've developed in close partnership with the Tacoma Pierce County Health Department called the Centers for Excellence, and it's kind of considered a consulting shop within the health department. So in 2011, through the National Public Health Improvement Initiative, or NIFI, sponsored from the Centers for Disease Control and Prevention, Department of Health got a grant, and with that grant, the concept was how can we improve and promote public health practices across the state. And so Spokane and Tacoma and Department of Health, Spokane and Tacoma were competitively awarded the grant funding to start the Centers for Excellence with Department of Health. And through that, we provide technical services and support to all other public health departments and their partners to help move towards accreditation, continuous quality improvement, updating processes, et cetera. That grant got pulled short 2 years in a 5-year grant, and Department of Health pulled out. Centers for Excellence through Tacoma and Spokane said, we believe this is still a service need. We think we're well positioned to provide that, and we think we can continue to provide those services under a fee-for-service model. So in 2014, Tacoma and Spokane continued, and we have been able to increase and expand through a fee responsive approach. So we do fee recovery for our services as well as Tacoma. So we have multiple funding streams, about 30 to 40%, depending on the year, comes and funds the staff in the data center from contracts, grants, and fees. So we do a lot of services in this community for our community partners under a fee. So that's kind of part of how we've grown. So you can see kind of the 3 big buckets that I like to communicate that we do is assessment, that's health surveillance, so continuously looking at the health status of our community and reporting that out and identifying when there's concerning trends. Then we have our evaluation bucket. So we have a really rigorous and robust evaluation staff that provides program evaluation, grant evaluation, project evaluation with clients across the state, including our own staff and programs. And then we have kind of this performance consulting bucket, which started at quality improvement, like lean, but we've also expanded for some other methodologies. So for instance, recently we've done a lot of training in TA with Better Health Together and Providence. We have multi-care coming up, where we're helping them use this results-based accountability to identify some strategies and data-driven decisions around community health improvements. So that's a little bit about us. So before I launch into this new product that we're making available, a little bit about the data sources. So we have a lot of different data. So it's one of the things that Data Center has is data. So we of course use the census. We have BRFIS, which is really health behaviors among adults in Spokane County, and it's a survey that happens statewide. We have data through the Healthy Youth Survey. I think Councilmember Thompson's probably familiar with that. It's used a lot in substance abuse prevention among youth. We have the CHAR system, so comprehensive hospital data. We have a pregnancy monitoring system, vital records, of course, so birth and death. And then quality of life, which is a jointly funded project by city, us, Empire Health Foundation, Province, so kind of multi-sponsored, and that's a local data collection effort that we can maintain local control of and therefore be really responsive to what information needs we have. And then recently we're really excited that we've onboarded this new system called Essence, and other locales that's called Rhino. It's syndromic surveillance, and really what this is real-time data coming out of our emergency department systems for like health issues coming out. So think about the utility of that during flu season, and you'll see an example around opioid use, smoke during August when the fire seasons hit us. So those are some of the applications for that. So all that data feeds into this new website that we have called County Health Insights. So this piece of work came about through the foundational public health funding efforts of the state, the WASALFO and Department of Health. So WASALFO is the Washington State Association of Local Public Health Officials, and they developed some pilot project opportunities to demonstrate shared services in regions. We were awarded one of those in partnership with our outlying counties, and so we took that pilot funding and we built this infrastructure with then the expectation with minimal additional financial input from our outlying counties, we'll be able to maintain this as a resource for our community partners in the region. So I'm going to walk you through that. Technology, don't fail me now. It's always a love-hate relationship. So this is what the website looks like. Very proud of this effort, that it was a collaborative effort, not just with public health people from each of the counties that you see, and there's one down here there too, Soton, but also with our communications program and our data center staff. So it was really a collaborative effort. We actually went through quality planning, design, and actually getting the data up in about a 6-month period of time, but we've been continuously building it, so I have not yet done like a formal push and release, even though this is being used throughout the region right now. Want to give a huge shout out for Amy Reif, as one of the data center staff who's been with us for 17 years, 15, close, okay, who is really leading the charge in our unit for developing and using Tableau as a data visualization infrastructure. So gone are the days where we can continue to produce kind of the static reports. We're really kind of moving to more of a quicker online presence around data, which allows us to be quicker in terms of dissemination and updating the data. So this is an example of what this looks like. You can see on average, we're looking at 53 different data points for each county. So you can kind of pick depending on what your county is. So we'll go to Spokane. Where did it go? There we go. So the different sections that you can see, we have our indicators, which is just our surveillance of core public health issues in the community. And so we maintain that, and our objective is as soon as we receive that data, we want to turn around and update this within 3 months, and I'll walk you through that. Then we have an initiatives and performance section. So those are things where public health spending a lot of extra attention on. So Dr. Lutz has spoken about the opioid epidemic here and the work going on. So we've recently launched an opioid dashboard through that. We are also working with some partners in the community. So in your handouts is a recent report that we were commissioned to do for the Women Helping Women Fund Foundation, so the State of Women and Children in Spokane. So that's under the initiative section 2. So we've committed to tracking those issues over time. We have an eye on equity section, which is kind of the next section we're really going to be developing. So with our agency's focus on continuously to promote health equity in the community, that's a place where you can go for information. And then there's newsworthy. So our unit frequently responds to media requests or requests for data from the community. And sometimes those investigations really leads to, wow, this alarming piece of information, it's trending in the wrong direction. So that's where we'll post and make that available as well. So I'm going to walk you through the indicator piece. So you can see here the key indicators that we track data on. We have some environmental indicators, health status, which would include like youth depression, which is a big issue right now, serious mental illness in the community. We have reproductive health, health behaviors, infectious disease, injury and violence. So those are all the sections. And then over here, which I probably won't have time to go into today, you can see the community voice. That's the quality of life data. So for those sponsors that are jointly funding that project, we make that data available there and it's queryable through that portal. So does anybody have a favorite piece of data you'd like to look at? An indicator, a topic? Vaping, youth marijuana. So I think the best place to look at that will be the newsworthy section, but let me see where we have. How about marijuana use? Youth, because they're also vaping that. Right. But we know that they are using marijuana through vaping too, but I don't know that we have vaping up here, do we? Next newsworthy. Okay, so hold tight because you flustered me because you picked one we are getting ready to produce. So that's going to be the focus of a newsworthy coming up. So you'll want to look back for that. So intentionally, we've tried to keep this really simple. So what's the trend? Well, it's getting better. Geography, what's the comparison to the state? And if there's disparities, what those are. So you can see that we're trending over time. So in Spokane County, youth marijuana use is going down slightly, but the trend, and it's statistically significant. So we are trending in the right direction there. About the same as Washington State. And then you can see by demographic, who and what are the subpopulations most affected. So you can see here a disparity in terms of mother's education, which is a proxy indicator for socioeconomic status frequently used in this data set. So for our local youth of lower income are more likely to be using marijuana. So that's how you can use this. Whenever possible, one of our commitments in terms of health equity, and which is just general public health practice, and this makes us a little bit different than some other local data sources out there, is we will always disaggregate the data as granular as we possibly can. And that really is what helps target interventions to the people that are most in need of those interventions and where resources should be applied.
Well, before you move on this, so of the data markers that you have in gender, youth females are more likely to smoke marijuana than youth males. Is that how I'm reading that correctly?
Male and female, they look pretty
they're
close.
Equal, but females are slightly higher.
Slightly, it's not significant. Yeah, if it was significant, it'd be called out here. So it's slightly higher, but it's not statistically significant.
What about birth defects and resulting from mothers smoking marijuana?
Great question. We are tracking maternal substance use, and that can be found in the newsworthy section. I'll go there in a minute, and we can look at that. So of interest to some people, and this is something I'd like, if you have time and an interest related to the opioid. So when you look at opioid use patterns in the community, we've really made every attempt to disaggregate the data whenever possible so you can see what's the trend for different subpopulations. So using this example, you can go and see, well, what's the trend by sex, grade, race. So in this example, you can see that marijuana use among Black youth is going down, right? But marijuana use among American Indian Alaska Natives looks like it's going up. So it's really looking at disaggregating the data so we can generate attention where attention is really needed.
So all data sets are not created equal.
True.
Do you perform, you say statistically significant, how do you determine, how do you determine if a data set actually provides value to what you're trying to forecast? Are you just running standard statistical tests on it, and then you figure out if it has a large enough population?
Yes, which is the.
Oh, sorry. I was just the question was all data sets are not created equal, and so I'm curious is that when we're summarizing these types of indicators and trends for general public, what are we doing behind the scenes to ensure that the quality of data allows us to make these assertions, and how we as an agency value and grade a given data set to ensure that the conclusions reached from that data are valid enough? 2 points make a line, 3 points make a trend, sort of thing. But at what point do we have internal standards that say we need a certain population of data, we need a certain robustness of that data before we use that data to generate these types of trends, forecasts, results?
So it's a loaded questions in here, so I'll try to answer it in different ways. One, if a data set's on here, it's because it has already been deemed valid, reliable, consistent through our qualifiers our standard of practice in public health assessment across the state, right? A lot of these data sets we don't actually manage directly. So for instance, the healthy use survey data is kind of a joint Department of Health and OSPI thing. There's quality controls that they build into that to make sure that it's actually represented. But to your point, no data set's perfect. There's limitations to any data set, which is why we have invested in developing the expertise we have. Whenever we're really investigating an issue, for instance, opioid, we will triangulate that data with other data sources and community context and knowledge whenever possible. So this is one source of information, but it's not the end-all be-all. So this tells you one thing about youth marijuana use, but we generally, when we're investigating, we don't just rely on one data point. We're going to investigate it more thoroughly. So to answer your question, yes, there's standards of public health practice in the state that we follow, and in the profession. We have our own technical procedures that we follow here. We have invested in highly trained, experienced staff who know how to report the limitations of the data and looking out for small numbers and when that's going to have an impact on how you interpret data. So in this case, Amy Wright, she will use, I think it's regression use, statistical testing to actually demonstrate whether there's a trend, for instance. So,
but the district data center has developed an internal QA/QC procedure.
Yes. Yeah.
And that is available as part of this if somebody wanted to look at that QA/QC.
The technical procedures.
Yeah.
If they wanted to, and I think aren't we in the process of building out the technical page a little bit more?
Okay.
Yeah. And it's not going to get into the nitty gritty details of everything, but it's going to give some general parameters of how we go about doing our testing and, those things. So.
Thank you.
Yeah. Hopefully they answer it. And Amy has something else to say. So every single data set that we have access to, we have to sign agreements. It's like a contractual agreement, which dictates how we can and can't use that data and how we can and can't report it, et cetera. So there's that whole layer too. Yeah. So here's the initiatives and performance section. So this is an example of some work that we're doing for different community partners under contract, as well as some of our own internal agency work. So Smile Spokane is an initiative in the county that's really trying to reduce oral health related disparities and improve access, et cetera. So we are the evaluators on that, and so that's a piece of project in progress. The State of Women and Children dashboard we just launched, so you can go there and take a look at the data points and kind of, what's the burden? So how many lives are we talking about? So this is something that we recently released just last week in addition to the report. So if you have interest, we can come back and talk more about that. But that's an example of a commitment that we made to a partner upon request and in a contract to actually track these issues over time. So that's an example. Dr. Lutz mentioned the opioid dashboard. So basically all the information that we currently have around opioid use in the community is located here and can be looked at. And we are actively talking now about expanding this to some other data sources, working with law enforcement, et cetera. So you can here you can see death, opioid related death, the hospitalizations, the ED, emergency department visits, neonatal abstinence syndrome, so kind of the impacts to infants that we're seeing in the community. So this is all information that can be found here.
Are you doing the same kind of thing with marijuana? All these, emergency room visits, hospitalizations?
Yeah, we have not developed a dashboard, but we have, we've looked at this recently in a report we call the Triangulum that's available on more of a technical report, but we have not made a dashboard on that yet. Is that of interest?
It's of interest because the public thinks it's legal and it's plant-based and therefore it's safe.
It's safe. Mm-hmm.
So we need to get out an education here about these actual effects and side effects that result from chronic use.
Yeah. So that's a great example of, responding to a community need. So if there's community need to have this data maintained in a greater amount and more in depth than what we currently have on our indicators, and we can explore that and produce a community dashboard around that topic.
Stacy, one of the concerns I've always had is how do you disseminate all this information to those particular health districts in your area? So the word is out of all this information and data. It's fine for us to hear it all, but here again, it's like speaking to the choir.
Yeah.
So how are you spreading the word, I guess, so to speak?
Yeah, so we have kind of a marketing and promotion plan that we're launching for this. So it'll include, we have a vast listserv of community partners that frequently come to us for information. We're going to send this out to them. I have a staff right now who's being paid under the Foundational Public Health Services pilot to actually use this data in the outlying regions. So, the administrators in each of those other counties are working with the data center to do their own community health assessment process. So last year, you might be familiar with the work of Priority Spokane that we helped immensely with. I have a staff that's basically doing that for each of these counties. So we're getting great feedback from the counties who have very little resources in terms of data capacity. So we really are their data hub and kind of surrogate staff. So that's another venue. Staff are attending meetings and showing these. So a lot of different ways we're communicating the availability of this data. It really depends on the venue and the setting, but kind of multi-pronged. So that's an example of a more in-depth dive on a public health issue. And then there's the ION equity page. And again, I could spend an hour walking through different data points, but I'll just kind of point out the main features and let you take it from there. One of the key pieces of data we released back in 2015, I think, was with our odds against tomorrow reports, looking at health equity. And we produced some data that showed differences in life expectancy by neighborhood. So that data we are going to be maintaining not live, but indefinitely here. And so you can look at that. So right now there's a 15-year life expectancy gaps between the highest, or the neighborhood with the highest life expectancy and the lowest. So that information's here. You can see how it kind of trends related to poverty, race, education. This is a piece of the website that we are going to be working out in greater detail with partners through our health equity initiatives. So this will be built out a little bit more.
I might add religion on there, because some religions have health codes.
Right, right. So,
And that subpopulation is not.
yeah. Religion isn't something that's commonly addressed in a lot of our data sets. We have some access to data around that, but not a great deal. Yeah. The final section of this would be the newsworthy. So things that are catching our attention in terms of trending in the wrong direction or the community seems to be having interest in. We have little fact sheets and kind of updates there. So you can see the life expectancy. There's like a little 2-page infographic there. Homelessness in the community, we've done some work with partners around that, so that information's there. Domestic violence, and then substance use and pregnancy, adolescent sexual health, so some different topics, and then they'll archive as they kind of get updated by more current. So that's the quick and dirty walkthrough. It is a lot of information, enormous source of information, and we're constantly looking for input to improve it and make it more useful over time. So as you explore it or hear about it, let us know what you'd like to see.
So I have a question about follow-up to Member Hafner's question about communication. A lot of times in the newspaper, there are articles or stories that are not helpful to the work we're trying to do. And so I'm thinking of domestic violence. Just recently, the woman in Spokane Valley whose husband took their son, stabbed her, and there was this article, a lot of things that people could read that article and place blame on the woman, saying, why was he in the house? Why was all these, why, just a lot of things.
Versus why did he abuse her?
Exactly. Yes. And so do you reach out to reporters and others who would be writing that? Because I've seen it in all kinds of issues. They're writing for the sensationalism of the story and to catch your attention, but not really sharing information that could be helpful to understanding why this happens and why we all have to get engaged in prevention and support of those who are being abused.
Yeah.
So
we've historically had great relationships with media. My unit responds to data requests pretty frequently and as proactively and quickly as we can, because it's important to counter some of the misinformation. So I would anticipate that would continue. I mean, under Kim's leadership, she was great about those relationships. And I mean, even since she's been out of the office, they've contacted us directly and we continue that. To your point though, they will be a huge audience for this in terms of we are going to really want to make a concerted effort to, convene, maybe train them how to use it, so they can start going there before they actually pick up the phone and call us even.
Yeah, I think that's a good idea. I know in the work I do on impaired driving prevention, I forget to, when I see a new reporter, sometimes I forget to call right away and say, please don't use accident, use crash record collision when you're talking about drug impaired or alcohol impaired. And I just think this proactive, because this is an incredible resource to the community. I mean, I've always said I just am so proud of our data in our community from the district, but I don't think enough people know about this. That, and I don't mean to add burden onto the work, but I'm just saying, it's time to brag a little bit and share a little bit about how awesome it is.
Thank you.
Yeah.
Thank you. Yes, we need to market this for sure. Yeah. The last little bit I'd leave you with is how can you help, right? So you're our board, and I'd like to say if you can help us spread the word about this, that would be immensely helpful. Identify opportunities or issues to bring in other data sources. So we are frequently in a position to help other community partners outside the public health sector with their data. So the Spokane Regional Domestic Violence Task Force is one of them. We're going to be working on a dashboard around that with them, but that's going to be using judicial data that we're not necessarily the front expert in. So we need to work very closely with partners. So that's capacity that we can bring to this community and helping people understand other data sources too. So help us with that. Any other questions before I think I need to?
I just had one question. If board members have questions about the quality of the data or something, and I mean, what's our process in the data center for someone raising an issue that they kind of want resolved or
Yep, I think start with me, and I have much smarter people that I would help have answer that question, like Amy. But start with me. We also have a web address, datacenter@srhd.org. So right now, a community member can email that, and we have somebody monitoring it that we can respond to. So that's another venue. Or just pick up the phone and call me if there's a concern or an issue, and we'll get it resolved. I think eventually we're hoping to be able to offer a help desk outward, because providing data is really important to the community. I'll give you an example of how our data has helped bring in, I think it was like a $400,000 grant around gang violence prevention. So we helped pull the data on gang violence around that. So it is a core function of ours. We try to turn around most data requests in 3 working days. If they're huge, we negotiate that time frame, but concerns, questions, if all else fails, contact me.
All right, well, thank you so much for sharing that, and I encourage all of us to spread the gospel of data. It's awesome. And next up is Tiffany Turner.
Good afternoon. Let's see. How do I make this large here? My name is Tiffany Turner, and I'm the program manager for both the Public Health Preparedness and Response Program here at Spokane Regional Health District and for the Ready Healthcare Coalition team. And I'm going to talk to you specifically today about the Ready Healthcare Coalition program. I believe next month Dr. Lutz is going to be giving you a little bit more information about the Public Health Preparedness Program and what we're doing to ready our community for the wildfire season that's already upon us. So I just wanted today to give you a brief overview of what the Ready Healthcare Coalition is, who we serve, the services and tools that we provide our healthcare community, and a little bit about the roles that we served in recent responses. And after I give a brief overview, I'm going to turn it over to Daryl, who's one of our primary healthcare partners, hospital partners in the community, to give you a little insight on how we work with hospitals in our community. So the mission of the Healthcare Coalition is to prepare for, respond to, and recover from crisis using all available resources to provide patient care at the appropriate level and in the most efficient manner. So we do this in working with a variety of partners in our community. Some of the ones being those that have jurisdictional authority in any type of incident, so the governmental agencies such as public health and emergency management. And then in addition to those partners, we really focus on the healthcare community. And that's a pretty diverse set of partners that we work with, focusing on the hospitals, but also those partners that support hospitals during an incident and that we need to work with prior to an incident for planning and training and such to prepare. But those healthcare partners can range from long-term care facilities that may be able to come in and help hospitals when there's a surge to offload some of their patients to be able to accommodate a surge of patients coming in, or it could be dialysis centers or blood centers that provide needed resources or supplies to our healthcare centers. And it could also include mental behavioral health providers in our community that are really critical to assist during an incident that happens in our community. And then as well as emergency support services that provide the transportation to our medical centers. And then recently, our federal funding comes from Health and Human Services Program, and specifically from the Assistant Secretary for Preparedness and Response. And then those funds are passed down through Department of Health and then passed down to healthcare coalitions in the states across the nation. So Washington State started out with having 8 healthcare coalitions in the state, serving different groups in the state, different counties in the state. And then just recently, in last year, as of July 1st of 2018, the Department of Health, along with guidance from our federal funders, have decided to take it from 8 coalitions in the state down to 2 coalitions in the state. So if you'll see the blue section here is what the Ready Healthcare Coalition serves. That's our jurisdictional boundaries. So we serve now from, we used to serve just the 10 counties in Eastern Washington, and the 3 tribes have now been expanded to serving 19 counties and 4 tribes in Eastern Washington. So everything from the Cascades West, and then there's also a coalition in the Western Washington area. And this preparedness region down here really works with the partners in Oregon because that's where their patient flow patterns go. And that's what a lot of our activities are based on, is where patient flow patterns happen, so those catchment areas. So our coalition consists of 3 different catchment areas, one being the Spokane urban area and surrounding counties where patients flow into Spokane to receive their definitive care. And then we also have a Wenatchee catchment area and a Tri-Cities catchment area. And the reason that those changes have happened in reducing coalitions throughout the nation is to start focusing on, the locals have been working together for a long time. You know, you deal with the locals, every response starts locally. So local hospitals work with other local hospitals and other healthcare partners. But they, our federal funders really want us to start focusing on how do we deal with those more large scale incidents that happen or those catastrophic incidents that happen, like such as Cascadia. If Cascadia happens, how do we deal with patient movement across the state? Or how do we, fly patients with highly infectious disease from one particular state to our special pathogens unit within Spokane that we have? So we really are starting to focus on those points of planning and preparedness. Some of the services that we provide as a coalition is really the Healthcare Coalition serves as that primary coordinating body. So we pull, again, all those partners together that I'd mentioned earlier, and we do a lot of planning. And we start off understanding where our risks are for our planning efforts. So we do what's called a hazard risk vulnerability assessment, and that tells us what risks we should be planning for. So it goes from anywhere from the natural hazards that happen, weather events, infectious disease outbreaks that happen, to man-made hazards. We have to be prepared to handle, a chemical, biological attack, all the way to other mass casualty incidents that might happen. We have a freeway that goes right through our city. We have train tracks that go right through our city, so we have to be prepared for particular hazmat incident that might happen, or a large pile up on the freeway that might produce a number of patients or fatalities. And so with those, understanding what those risks are and those hazards, we do quite a bit of planning. So again, we have different plans that we pull together, key partners, healthcare partners, and other responding agencies together to talk about, okay, if we do have an incident that happens, how do we take those patients and move them from the field to the hospital, or to where the best place is for them to receive their definitive care? So we have to understand how that EMS transport is going to happen and move those patients, and what resources do we have out there to do that. And we also do planning around patient placement. So when we do have a mass casualty incident and there's 25 patients, we can't obviously all send them to one healthcare facility. So we do have a system in place that tells our transport agencies where we need to send those patients and who can handle it based on what the level of care is that they need. And then we also have planning around plans around patient tracking. So we have a patient tracking system that the Healthcare Coalition manages that's called WATRAC, and that allows us to be able to track, when there are multiple casualties happening in an incident, how do we know what patient is going to what facility? Because that's really important when it comes down to that family reunification, right? That, families are going to want to know, where is my loved one at, which healthcare facility? And so that system allows us to be able to track those patients. And then we do other specific plans around specific hazards or around incidents. Like we want to do some specific planning around pediatric response. So pediatrics, take special considerations that we need to put into our planning processes. We also have to do planning around burn victims. So as you know, we don't have a specialized burn center in Spokane. So how do we get victims that are injured by burn incidents, how do we get them over to Harborview to receive the proper care that they need? And we have other specific planning that we're going to be doing around chemical radiological hazards and around highly infectious disease hazards incidents as well. And then we also have started a group here in Spokane that's called a Disaster Clinical Advisory Committee. What that group does is they start addressing crisis standards of care. So that means that when there is an incident that happens and we have to alter our standards of care to be able to serve as many that we can, then how do we do that? And who makes those decisions? That's important for partners to get together to discuss those prior to an incident happening, because you don't want to have to make those decisions when an incident happens. An example of that can be such as when we have a really bad influenza season and we have multiple patients that are on ventilators, but we only have so many ventilators in our community. How do we decide as a community who should get those ventilators? Do we give it to the youngest person? Do we give it to the first person that comes in the door? If we give it to that first person, but somebody else comes in that may need it more, do we take it from that first person and give it to another person? So there's some of the really ethical decisions and hard decisions that need to be made, but it's important for us to start those conversations now. So those are some of the planning pieces that we do. And then, of course, we also train and exercise to all the different plans that we have, as well as bring other partners in that have gone through these different types of incidents to learn from those partners. What happened? What did they do? How can we prevent ourselves from making those same mistakes and make our planning better? And so we bring in speakers that talk to that to learn from. And then we have a big part in providing our healthcare partners with support during incidents that happen. These are a couple of the recent incidents that happened. If you remember the bus crash that happened on I-90 with all the University of Washington students that were on that bus. And so that is now in our jurisdiction. And so the Healthcare Coalition was able to send out alerts to those healthcare facilities when that incident happened and they were notified of that incident, that we were able to send out alerts to those hospitals saying, hey, heads up, this is happening. You need to be ready to receive patients in your facility. So that's important for them to be ready for that. And then again, an incident like that could trigger the Healthcare Coalition to activate our patient tracking program. And again, those families, those students that are on that bus have all the families that are wondering, where did my kid go? And so this system would allow that family reunification to happen, to know where their loved ones went. We also had a part in the recent saline shortage. I don't know if some of you recall, but that was a nationwide shortage of saline in the nation due to the hurricanes that happened. And so the Healthcare Coalition was able to connect different healthcare facilities that had a dire need for saline that were running short, and they couldn't reach out to their normal suppliers because they didn't have the supplies either. So we were able to coordinate that connection with other healthcare facilities that were able to share some saline with other facilities that needed that saline in an immediate time. And then we also did some work around influenza seasons when we had those massive surge on healthcare facilities, and how do we work with those healthcare facilities to find out, how it's impacting their facility. What is the status of their facility? Are they full? Are they able to receive patients? What is your bed status right now? Can we send more patients to you? How can we help you offload patients to other facilities, or keep other patients keep people from going to the hospitals that don't have those immediate needs? So those are all pieces that the Healthcare Coalition helps with during response. So besides alerts, we also do, and patient tracking, and the resource coordination, we also do what's called information sharing. And that's where we have the ability to send out a survey to all of our healthcare partners in our jurisdiction and ask them, okay, what is your bed availability, or what is your supply of this particular, during the measles response, we sent out a survey, how much IG do you have in your facility, and are you able to share that if need be? And so we send out those surveys, they respond back to us, and then we are able to aggregate that information and send it back out so healthcare facilities understand what the status is of other healthcare facilities and what's happening in our communities. So information sharing is a really big part of what the coalition does for our healthcare partners. So they're able to make the decisions that they need to make based on that data. And so right now I'm going to turn it over to Daryl to give you a little spiel about Providence.
Hi, good afternoon. My name is Daryl Ruby. I'm the emergency manager for Providence Healthcare. So in that capacity, I support our Providence hospitals in Spokane and Stevens County. I spend probably way more time than I should at Sacred Heart, but I also support Holy Family, St. Luke's, our ambulatory surgery center, and then our critical access hospitals up in Stevens County. I appreciate the opportunity to kind of represent the ever-growing membership within the Healthcare Coalition. I've been at Providence for almost 4 years now, and previous to that, I was with Greater Spokane Emergency Management. So I've had the really good fortune of working both with the Ready Healthcare Coalition, the former Region 9 Healthcare Coalition, Spokane Regional Health District, and some of the other partners. And they really do a fabulous job of sharing of information. In the emergency management business, really one of the most valuable tools we have is relationships and information. Communication, you often hear in exercises, is always kind of that number one lesson learned. We never do it well, it seems like, but one of the things I'm really proud of the Healthcare Coalition and the work they've done really for all of us that Tiffany touched on was that situational awareness, sharing, and the ability to reach out to partners, gather information so that the decisions that are made with a little bit of data. One of the many challenges of emergency management is there aren't really great standards out there. So we can all have good programs, but it really takes those relationships to collaborate and to work across county lines. I do want to highlight a few of the things Tiffany mentioned and hopefully a couple of more. The one that I was reminded of that I hadn't planned to talk about, but I don't know if it was shared with this body. Last year, we had a national level full-scale exercise. It was called Tranquil Terminus, where we moved some patients from actually 4 different regions. So the Health and Human Services, or FEMA regions, 4 different regions were involved. We moved some patients from Boise, and 2 were dropped off here in Spokane, and then 2 went on down to Los Angeles. As Tiffany mentioned, Sacred Heart is designated as one of the 10 regional Ebola and other highly infectious disease treatment centers. And so in that capacity, we represent Washington, Idaho, Oregon, and Alaska. And so Dr. Lutz was interviewed. I don't know if you guys were made aware of the video, but it was a really pretty high quality video that did a really nice overview of that effort and kind of that broader, it was focused on Ebola, but it really translates very well to pandemic, which certainly the health district knows better than I ever will is something that we have to continue to prepare for. So that was a great effort. The Healthcare Coalition helped us plan, design, and evaluate that exercise and got lots of our partners involved. A couple of the other plans I wanted to talk about was the patient surge. So Tiffany mentioned the work that we've done there. I've been involved with really planning in the Spokane and regional area for almost 15 years now. We've had a patient surge plan. It's called Disaster Medical Coordination Center for a number of years. Up until just a few years ago, it was really pretty much a theoretical plan, mostly in the mind of one person who used to be at one hospital and now he's at Sacred Heart, fortunately, but it had never really been translated to be a true plan and operationalized. And with the support of the Healthcare Coalition, and this goes back to really well before Ready and the broader 19 counties that they support, but we really started to operationalize that, and the support that the Healthcare Coalition gave to Deaconess, who serves as our region lead for Disaster Medical Coordination Center, has really helped us move several steps forward. And we have a lot of work still to be done. But where that becomes important is if you think about the Freeman school shooting, and fortunately there was only 3 patients. They did all come to Sacred Heart, but really, the big idea around patient distribution, as our ER director tells me, even though we're very biased to Providence and Sacred Heart, that you'd rather be number 1 at Valley than number 10 at Sacred Heart. And that's kind of the concept of the patient distribution. In the Freeman school shooting, fortunately, we didn't necessarily have to exercise that, but what was exercised was the coordination and the support of the Healthcare Coalition, the activation of the Disaster Medical Coordination Center, which Deaconess leads in our region. And then if you kind of fast forward now to the Ready Healthcare Coalition, they're supporting 4 disaster medical coordination centers. So in their regional distribution of the 19 counties, there are 3 kind of regional or sub-regional disaster medical centers that do that patient distribution. And then Sacred Heart is designated as one of the 2 statewide disaster medical centers. So just yesterday, we did a statewide exercise where Department of Health initiated through the Ready Healthcare Coalition duty officer and kind of their new response role, a National Disaster Medical System, so NDMS request. And so that request went from the Department of Health to both Healthcare Coalition's duty officers, which then went to Sacred Heart and Harborview on the west side. And we did a communication drill and learned several things in the plan that's ever growing there. Tiffany touched on the saline shortage that they helped out with. I'd kind of like to add a couple of specifics. And really, that was done because of the relationships that were made primarily through the Healthcare Coalition leaders and partners. Because healthcare, one of the things that actually drew me to healthcare was that healthcare doesn't really know any statutory or jurisdictional borders. We often get really hung up in that, but healthcare doesn't so much. They really just want to place the patient in the best place for them. And that saline shortage was a good example of that. Kootenai Health across the Idaho state line, not in the Ready Healthcare Coalition, not in the Region 9 Healthcare Coalition, but through the relationships that were made, needed some saline. And Providence and Deaconess, Multicare were helping Kootenai for a while, but lo and behold, the VA hospital, which I often joke is kind of a pretend hospital, they are an amazing facility. I'm a vet myself, so I can poke a little bit of fun at them, but they're very different than the rest of the healthcare systems. And what the Ready Healthcare Coalition was able to coordinate, actually I think it was back when they were the Region 9 Healthcare Coalition, was saline from the VA, so think about it, a federal partner who doesn't always play well at the local level, ours does in particular, and they were able to help facilitate the transfer of saline to Kootenai Health, so not just within our own region, but across state lines. And so, you know, lots of work behind the scenes, lots of relationships that were leveraged, lots of new relationships that were made. The other thing that I really wanted to talk about is a couple of years ago, really our last large flu season outbreak, we realized that across the hospitals in Spokane, which sometimes play well together, other times does not, we really needed to come together. And so the Healthcare Coalition facilitated a meeting by the chief nursing officers of Valley, Deaconess, Sacred Heart, and Holy Family. And in that information exchange, we were able to get some direction from those senior-most leaders on the operational kind of priorities of the flu season. And we were able to both capture some data and make some good decisions that we've really benefited and will continue to benefit in the future. So those are really some of the highlights that I'd like to mention. I'd be happy to answer any questions. I really am just one of the many partners that the Healthcare Coalition supports, which really includes public health. It includes local emergency management, as well as obviously the hospitals and the other suppliers and providers in the broader healthcare industry.
Thank you. Any questions for either Daryl or Tiffany? Comments?
I'll make a comment. Nice to see you again.
Very nice to see you, Chuck.
Yeah. All right, thank you very much to all the presenters today for giving us lots of data and information that we can share with the community, and also just keep in mind as we do our oversight of the agency. There's no more public comment, just board check-in, and I'll go this way. Start with Dr. Condon. If you have any board comment at the end.
No comments.
Okay.
Yeah, I'd like to comment to piggyback on what Linda was saying about communications, is that the communication officer is like such a complex and challenging position, and that I hope that the health district puts a wide net out there so we have a good pool to look at, somebody who can understand what's going on in the public health and in the community at the same time, and that they look at it as importantly as they do an administrator.
Member Thompson.
Thanks. Well, every time we meet, I just see more and more ways that we have nets that can work together. And I know it's really late this afternoon, but at 4 o'clock today, the drug court graduation is happening in courtroom 4 with Judge Clark. And it's folks who have suffered from opioid addiction and other addictions that are now successfully in recovery and moving on with new jobs and all kinds of success. And just, there's so many partners that are supporting the health of our community, and just encourage you with more notice to go to the drug court graduations or other things where we can see success, because there really is success happening in our community.
I just wanted to note that we did have it's Bike Anywhere month. We had Bike Anywhere week, and we had some really good discussion in the city over bicycling options, voluntary options.